maybe you also know Elaine. We'll go ahead and move towards Elaine.
Hi, I'm Linda Reed. I'm the chair of the nurse practitioner programs in the graduate division.
Hi, Benita Heskis. I'm the assistant dean for the graduate division.
Nice to meet you.
Linda Dickon, I'm the chair of the BSN program.
And Grace Morphew. We met.
Hey, good to see you again.
And Jude, you are online. Would you introduce?
All right, nice to meet you.
Is anyone else with us online? Okay. At some point, Angel may join us online as well. She's the site director out in Atlanta area. And she's not on this one. Okay, so Melinda, if you'd open us in prayer and then we'll move to your presentation, Carrie.
Okay.
All right, that's great. Good morning, Lord. Thank you for this time to come together and have discussion about potential candidates, Lord. May you guide us and lead us into your truth. We submit to your will. We thank you for your goodness in Jesus' name. Amen.
So we're launching right into it.
Yes.
Great. So let me just see. All right.
Clever. I like this. You're spinning. Yeah. This is good.
So yeah, it just keeps loading and loading. So, so my name is Gary Mittelberg, and I am going to be talking about bipolar a little bit today. So I am instructor for mental health theory, and so I've taken some of my slides from a presentation on bipolar. So
I'd refresh the browser.
I'm sorry.
I'd refresh the browser.
Okay.
It's on now.
Because of the
Okay,
logo.
sorry.
I think it's okay. So the nice thing I like about teaching mental health theory and clinical is that very often we talk about what diagnosis we have in mental health, maybe on Tuesday in lecture, and then Thursday when you're in clinical, we actually see them. Bipolar, major depression, schizophrenia, schizoaffective. Not always the personality disorders do we see because they're a little bit more rare, but that's what a lot of my students talk about, is that we talk about it and then they turn around and see it. Whereas sometimes in med surg, we talk about a lot of different diagnoses, and we don't always see them in the clinical site, but we see bipolar pretty much every week in every setting. So, and bipolar would be the axis 1 or the primary diagnosis, whereas I mentioned personality disorders would be axis 2 or secondary diagnosis. So what is a clinical picture for bipolar? So bipolar is presence of one or more manic episode that lasts at least a week with a patient. And what does a manic episode look like? It certainly is pretty much everything is elevated, right? Where we have increased verbalizations, increased activity, hyperactivity. And this was once known as manic depressive disorder. So in bipolar, we're going to have at least 1 week of manic episode. And then also episodes of depression and or hypomania as well. So bipolar 2 is slightly different than bipolar 1 because we're not going to have the mania that we have with bipolar 1. So we're going to have, with bipolar 2, we're going to have hypomania, which is not going to be quite as dramatic as the mania that we have in bipolar 1. So we're going to have we can have profound depressive episodes, presence of history of at least one hypomanic episode, but we're going to have no mania. And the hypomania feels euphoric, and at times can even help us or help a person with some functioning and getting things done, but over time, they're going to deteriorate. So some people say it's not unlike maybe a triple shot of espresso or something at Starbucks. Actually, one of my students recently said somebody behind her ordered a 10 shot. I don't know if I've ever heard that. And I thought to myself, I wonder, is there a cutoff, like how many shots you can get, or you know,
ounces in a 8 ounce.
or you have to sign a you know,
Disclaimer, waiver.
disclaimer or waiver or something. Woo. And then we also have cyclomania. Cyclomania is similar to bipolar 2, but it's not going to have quite the highs or the lows. You're going to have alternate symptoms of mild to moderate depression and hypomania, and it's going to last, and this is the key that I talk about with students, is it has to last at least 2 years to be diagnosed with cyclomania. People with cyclomania can typically function in daily life, though it may be difficult for them, and sometimes, almost with many of our diagnoses, with added stressors, you can deteriorate and then have more problems. Some are rapid cyclers and have maybe 4, 6, even more episodes per year of cycling, and some even cycle much more rapidly, even possibly in 24 hours. So what's a clinical picture look like? So this is what I always talk about with my students. One of my favorite psych terms, and I use a picture of a roller coaster, which is up and down, which is labile. Now you can also have labile blood pressure as well. So it's anything that's kind of rapid cycling, going up and down. And this is one of the key things that we see with bipolars is they can have some labile behavior. So it's really can be up and down and varied. And some, like I said, some can cycle more quickly, and some might take months to be able to change from mania to depression. So epidemiology, as far as the prevalence of bipolar disorder, in the general population, it is about 5%. So 5% of the US, oftentimes I'll say, does anybody know how many people there are in the US? So my students guess anywhere from a few million to a couple billion. And so I don't know if anybody in this room knows, but we actually have about 335 million. So we're talking about 16, 17 million people that suffer with bipolar disorder. As opposed to schizophrenia, which is only about 1% of the population. So only about 1/5 as many. And then depression, which actually has at least twice as many, about 10% of the population has major depression disorder. So median onset for bipolar is about 18 years of age for bipolar 1 and about 20 years of age for bipolar 2. Bipolar 1 is more common in males, bipolar 2 is more common in females. Cyclomania or cyclomania is usually begins in adolescence or early adult, and there's about a 15 to 50% chance that it will develop into bipolar 1 or bipolar 2 disorder. And once again, cyclomania is rapid feelings of elation with minor depressive disorder. Or feelings, and it lasts at least 2 years, but it's usually not as severe as bipolar 2. So what, in our assessment, what are we going to see with the bipolar? So mood, like I said, typically everything is pretty much elevated. Their speech pattern, the volume of their conversation and their voice, their activity, their vital signs, usually pretty much everything is elevated. Euphoric mood associated with mania is unstable. It's a general expansiveness. So what is that behavior going to look like? It can be quite unstable at times. So they can have really a grand appetite for social engagement, spending, activity is just, like I say, very elevated, hyper, sometimes even exercising for long periods can lead to hypersexual feelings, can be very promiscuous. So some people who have been in a stable relationship who then start becoming hypomanic or especially manic can all of a sudden have multiple partners, be making really poor decisions, and it can just be like, what has happened to Mary? You know, she was doing quite well, and now I see her with different guys. So it can really lead to some risky behavior. And so what kind of things do we see, especially with the bipolars as far as their needs? So what they will be doing in their hypomania or their mania is they will not be sleeping or eating. Just think about that. If you're feeling, really energetic or kind of hyper, usually it's harder to sleep and you don't have as much appetite. I talk to students sometimes about when you feel like you are maybe infatuated with somebody, and you're so excited, and every day it's bright and sunshine, and sometimes you're not really hungry and you don't want to sleep because you're thinking about this other person. That can be similar, and that can be a difficult stage sometimes for some people because you can't stay in that infatuation forever because the body sometimes can wear down, similar to mania. So that is one area that we really have to focus on with our patients. And when we think about Maslow's hierarchy, the sleep and the nutrition are some of our main focuses. So one large difference between bipolar 2 and bipolar 1 is the thought process. So with bipolar 2, they're not going to have mania and they're not going to have thought process disorder, such as hallucinations, potentially clang associations. I don't know if anybody knows what clanging is or clang associations, where it's a rhyming, like, for example, might be person in the last row, row your boat, and ship, slip. Just rhyming just doesn't really make sense. Can have neologisms where they're making up new words, word salad potentially. So different things with their speech patterns can.
I'm starting to worry that I might have this.
Yes, I have.
Yeah, if anybody wants to talk to me, let me know. So mania is going to have some of these thought process disorders. Potentially, the bipolar 2 is not going to. So if you have anybody with bipolar who is hallucinating, delusional being, false fixed idea, talk to my students, what do delusions look like? Give me an example. So anything like I have a chip in my head, or I'm Superman, or I'm Jesus, or people are, government's after me, which we do have to look at that and drill down on that, because we have had patients who come in and say, a gang is after me. And that could be true. I also use an example of a patient who one time she was older and she said, oh yes, I'm very wealthy and I own 5 homes and all these things. We're thinking, oh yeah, I've been into this delusion. But the family came in and said, we tested that. And they said, well, actually, yeah, she is very wealthy and she does all that. Like, okay, so we changed my charting on that one. So cognitive functioning issues greater with bipolar 1 and we don't have that with bipolar 2. So what are we going to see? Somebody comes in with mania, what are we going to see? Hyperverbalness, pressured speech, self-destructive activities potentially, decreased need for sleep, decreased appetite, provocative behavior. These are the kind of things that we will see with bipolar. So patient admits in a manic state. Those are the kind of things we're going to see. Excessive talking, racing thoughts, distractibility. So what are our priorities going to be? priorities are always in mental health. Exactly. So safety for the patient, safety for ourselves. I really hammer that home in clinical that we have to really be watching out for both. So,
We just had an incident with a student.
yeah. And so I spend quite a bit of time the first day when I have clinical, just talking about expectations, rules, and trying to make them feel more at ease, but also let them know the seriousness of the patients that we do work with. But I really I encourage them that they're going to have a great clinical, and they do. And I tell this story about that I've taught for a very long time, and over all my time teaching, I've only had one student that in my realm that's really been injured. Out of thousands of students probably that I've seen, either as director or as instructor, or coming to my unit and stuff, and they, that's pretty good, but yeah, one student got injured. Then I go on to say, well, the big reveal, the rest of the story is the student actually didn't get injured in mental health. He got injured, and it was a guy, he got his nose broken actually. He got injured in labor and delivery. So I talk about that you can have potentially violent behavior everywhere. Yeah, it was actually a visitor, a significant other, that got upset with the patient. He stepped in, and so I talk about the importance of, taking these principles that we learn in mental health and using them everywhere, because you're going to see patients with mental health issues all throughout the hospital. So some other priorities that we have. So let's say a patient with bipolar comes in and admits to our unit. What kind of things are we going to think about? Safety, where are we going to place this patient? So we're going to want to try to have a low stimuli, calmer unit as much as we can. So what does that mean as far as placing a patient in the unit? So would we put the patient close to the nurse's station with the roommate? No, we would actually do the opposite. Nurse's stations are high stimuli, high action, really loud. So we want to place them furthest away from, unless there's some kind of safety issue that we need to watch more closely. But typically we place a patient far away from the nurse's station without a roommate. And why do we not have a roommate? Because the roommate actually will probably have a hard time with a manic patient, because a manic patient, until they become more stable, are going to be loud and maybe up during the night. So in those occurrences where we do have place somebody, the roommate sometimes comes and says, I need a new room, I need a private room because I can't be with this person. And I say, well, unfortunately, I'm probably gonna have to give the private room to your roommate, because anybody I put with this person will probably have difficulty. So as opposed to somebody who comes in who's depressed, the opposite, depressed and suicidal, we usually put real close to the nurse's station with a roommate. It can actually be another set of eyes on the person, and maybe somebody who can also, if there's a problem, tell the staff and let us know.
Gary, I'm gonna stop you in your presentation now just because we're at the mark of time.
I've got so
Is
much
that
more to
okay?
tell
I know.
you though.
Which is so lovely, because that means you're very passionate about this area. I feel like I've learned a lot.
We didn't even talk
listening
about
to
lithium.
you.
No, okay.
So we'll get to lithium some other day.
Totally.
But we're gonna move into our set of questions, so we make sure that we have time to ask you
Yeah, absolutely.
some of these things. So maybe actually, if it's all right, I'll start
Yes.
by just asking you if you can tell us why APU and why now, and what makes this a right timing and a right place for you
Okay.
to join faculty.
So, as I told some of you, I actually met one of your instructors, Nikki, at a Maranatha swim meet. Both of our kids are swimmers, and my wife was talking